Dr. Berger earned his Bachelor of Science degree from the University of Wisconsin with a major in biochemistry and molecular biology. He then went on to attend medical school at the David Geffen School of Medicine at University of California, Los Angeles to earn his MD. He also completed his residency in urology at the NYU Langone Medical Center in New York. And Dr. Berger completed a fellowship at the University of California, San Francisco in laparoscopy, endourology, and robotic surgery. Dr. Berger has a special interest in prostate cancer, ranging from robotic surgery to state of the art treatments of advanced and metastatic prostate cancer. He also has extensive experience in BPH procedures and is fellowship trained in complex kidney stones and also has an interest in ED and penile implant surgery. So, Dr. Berger, thank you so much for giving us your time tonight, and I'll turn it over to you.
Great. Thanks, Jack, and thanks to everyone who's joining tonight to learn a little bit more about prostate cancer, and thanks to Jack and the rest of the folks at Boston Scientific for sponsoring this for us. So our agenda tonight is just going to go over some prostate cancer basics as far as anatomy, where the prostate is and what it does, some of the statistics about prostate cancer, how prostate cancer is diagnosed, the treatment options, focusing specifically or mainly on radiation treatment options, along with the SpaceOAR Hydrogel treatment. So what exactly is the prostate? Get this question a lot. So basically the prostate is a small gland that sits in between the bladder on one side and the urethra or the urine tube going through the penis on the other side. The main function of the prostate is really just for reproduction. It makes some nutrients and proteins as part of the reproductive pathway to keep the sperm healthy and swimming to go find eggs. So once men are past their reproductive years, you really don't need a prostate any longer. But certainly as it grows, it can cause a lot of urinary symptoms just because of where it's located between the bladder and the urethra. But certainly, as we'll be focusing on tonight, it is a source of problems in the form of prostate cancer, which is very common for men, as we'll get into. The procedures oftentimes we do for prostate cancer, as we'll get into, are transrectal, since the prostate is sitting right next to the rectum. So a lot of times for doing imaging of the prostate, we'll do ultrasound imaging transrectally, so through the rectum to visualize the prostate. And also when men go to get their prostate exam with their doctor, we normally do a finger check or a digital rectal exam going into the rectum. That's how we feel the prostate. So as far as statistics, about one man in 9 will be diagnosed with prostate cancer during his lifetime. For certain populations, such as African-American men, it's actually more common than that. And it still is the second leading cause of cancer death in American men, behind lung cancer. In the United States, these are 2018 numbers, but probably fairly comparable to where we're still at. But new cases around 160,000. Death rate is still close to 30,000 a year. The 5-year relative survival rate for localized prostate cancer is close to 100%. 5-year survival rate for all stages is still pretty high, 99%, and 10-year relative survival rate for all stages, 98%. And the key thing here is that prostate cancer is diagnosed early. It is very treatable. With a lot of the medications and new options we have, even if it's diagnosed at a more advanced stage, we normally can keep it under control and make it more of a chronic disease for many years. But certainly early detection and early treatment is still a good mantra for prostate cancer, as it is with many other types of cancer. So screening is certainly important. So how do we diagnose prostate cancer? So there's a couple different methodologies we use. The mainstay of screening is the PSA, which stands for prostate specific antigen, which is a blood test, along with the digital rectal exam, which I just mentioned, where your primary care doctor or the urologist is actually feeling the prostate to see if there's any asymmetry, seeing if there's any hard nodules and anything abnormal. But really the mainstay of diagnosis that most of our prostate cancer patients are found with is the PSA blood test. Now, it's not a perfect test, can be falsely elevated for other reasons. That's why it's a little bit controversial, and that's a whole nother talk. But certainly myself and most people that do a lot of prostate cancer and most urologists or cancer specialists would recommend getting a PSA at least periodically. And if you're in a high-risk group, such as African-American men or patients with a family history, you really should be doing this on a pretty regular basis, starting at age 50, or if you're in a high-risk group, even at age 40. Non-screen detected prostate cancer is when a patient is diagnosed during the workup of symptoms. So if a patient has pain, urinary issues, bleeding, weight loss, decreased appetite, other symptoms like that, and then they do testing and find that they have either signs of metastatic disease on imaging, or if we do a PSA when a patient has symptoms and they have a pretty high PSA level. Unfortunately, a lot of these patients are no longer organ confined, especially if they have spread to their bones or other organs on imaging. So that's the importance of screening. We want to try to catch it before it gets to that state. But the biopsy, which we're going to show you a picture of in a moment, is also really the best way to diagnose cancer. So like many other solid organ cancers, really the way to diagnose that is with a biopsy. You actually need to get tissue under a microscope so they can look to see is there cancer or not. So this is really how we confirm if there is prostate cancer or not, is with a prostate biopsy. So the prostate biopsy has a couple different approaches. The traditional approach, as I mentioned earlier, is with a transrectal approach, which is where you have the ultrasound probe that goes in through the rectum to visualize the prostate. And then the biopsy needle actually goes into the prostate through the ultrasound probe to sample the prostate tissue. On a typical prostate biopsy, we would do 6 samples from each side, so a total of 12 samples. And we're sampling the lateral aspect of the prostate. So the sides or edges of the prostate is typically where prostate cancer forms. The central part of the prostate, that is what typically enlarges as men get older and can cause urinary symptoms, but it's unusual to have cancer in the central area. So we're typically just sampling the periphery of the prostate. A newer technique that is becoming a little bit more popular of late, basically we still have the ultrasound probe going through the rectum, but the actual needles are placed through the perineum. So that's the area under the scrotum, but above the anus is called the perineum. And the needle goes directly through the skin there. The advantage there is since you're not going through the wall of the rectum, it can pretty much eliminate the risk of any significant infection since you're not going through the rectal wall. This is a little bit newer technique, does take a little bit longer to do it this way, but this is becoming more popular to eliminate the risk of infection. So determining the severity of prostate cancer. So there's 2 key elements that we look for when we're diagnosing, when a patient's been diagnosed with prostate cancer in terms of figuring out their prognosis and what should be done. So for non-metastatic disease, the grade and the stage is important. So when the pathologist looks under the microscope and sees something that looks cancerous, they will give it a score, which is described by Dr. Gleason from the Mayo Clinic many years ago, called the Gleason score. And this is typically a number made up of 2 distinct numbers. So the Gleason score is a 1 to 5 scale. But for all intents and purposes, these days, no pathologist will call anything cancer below a score of a 3. So the 2 numbers involved will typically be a 3, 4, or 5. And then they take the most common pattern, put it together with the second most common pattern. So you'll typically see things like a 3 plus 4, or a 4 plus 3, or a 4 plus 4, 3 plus 3, to get the final number, typically between 6 and 10. Since this gets a little confusing, some of the key pathologists that work at prostate cancer came up with this grade group, which is a 1 to 5 scale. So 1 being the least aggressive form of prostate cancer and 10 being the most aggressive. So we've kind of moved more toward this grade group to help patients make it a little bit easier to understand, because a 1 to 5 scale where you're not having to combine 2 numbers does make things a little bit easier to understand. So that's the grade. And then the stage is what's called the T stage. And this has a couple of components, including imaging. So if a patient has a little bit more aggressive type of cancer, we'll do a couple X-ray tests like a CAT scan or bone scan, MRI scan, to determine if there's any signs of spread, either locally or other places such as bones or lymph nodes, or lungs or liver. Those are common places prostate cancer can spread, as well as the clinical exam. So if a patient has a nodule, for example, on their prostate exam, that automatically will take it to a stage 2 just by the fact that they have a nodule there. And that's called the clinical stage. So the vast majority of patients who we diagnose by a PSA test alone, and they have a normal exam and everything else seems normal, no symptoms, is categorized as what's called a T1C, meaning this is cancer found by the blood test alone. And that's the majority of prostate cancer patients are a clinical stage T1C. Now, the pathologic stage is different. That's the pathology from like if you have the prostate removed, and we'll get into treatment in a second, then they can give you a final pathologic stage. But most of the initial staging is the clinical stage is typically a T1C. Other factors that we use to help determine if a patient needs to be treated, if a patient can be observed, how aggressive we need to treat it is something called the PSA velocity, which is how quickly the PSA has been rising. There's also a variety of what's called genomic tests, which is where there's a few different tests that will take samples of the prostate cancer and do some additional genetic testing and come out with a score saying for a specific patient's prostate cancer, is their prostate cancer going to behave more aggressively, less aggressively, or kind of average for their grade group. So if a patient is on the fence about, okay, should I be treated? Should I do surveillance? And they come back and do genomic testing, comes back with a high score, that's probably a patient that we don't want to observe and that we want to treat. Also, the volume of the tumor, as I mentioned earlier, we typically do a 12-core sample of the prostate. So there's a big difference between having a patient who has one small area of cancer on one sample out of 12 versus someone who is like 11 or 12 out of 12. Okay, that's a much higher risk patient when the cancer is on both sides, front to back, rather than in just one area. And there's some additional risk assessment tools. There's something called the Capper score. There's something called Parton tables. There's the National Comprehensive Cancer Network has a risk stratification scoring system from very low risk up to very high risk that we can plug in a patient's information and kind of come up with a risk stratification to determine, how they should be treated. Common treatment options for prostate cancer in general. If it's a low-grade tumor, low-volume tumor, a lot of times these days we'll just do active surveillance, which sometimes sounds weird to patients that there's cancer. We just discussed, okay, we did a biopsy, we found cancer, but we're just going to watch this. Sometimes they kind of are shocked by that, but for prostate cancer, that is a very common pathway that we choose just because years of research and data has shown that for low-grade cancers, like those grade group 1s, they have extremely low risk of metastasis or causing any long-term morbidity or mortality to the patients. So we have a lot of patients who choose active surveillance, and that just typically involves doing repeat blood testing with that PSA on a 6-month basis, and then we'll often do repeat MRI scans or other imaging scans just to make sure the cancer is not getting any worse. Certainly for patients with more high-risk disease or moderate risk disease, especially younger patients, they may opt for surgery. So the vast majority of surgery done these days in the United States is done with what's called the Da Vinci robotic prostatectomy, which is a minimally invasive surgery where we make 4 or 5 little tiny incisions in the abdomen under anesthesia and look in with a camera and this large fancy machine called the Da Vinci robot, where we're able to dissect out the prostate, remove the prostate from that area between the bladder and the urethra. And we do our best to spare the nerves to keep the erectile function working well. And also when we put the bladder and the urethra back together, we can see very clearly and get those connections made so the patient has very short-lived urinary incontinence, which is one of the potential side effects of the surgery. But the surgery does remove the entire prostate and has excellent outcomes as far from a cancer perspective. And the third option, as far as treatment is, we'll be focusing on a little bit more tonight, is the radiation. So radiation therapy, I find from talking to patients, there's a lot of misconceptions about radiation. I have a lot of patients, when you mention radiation, they say, oh, I'm not doing that. I had a friend who had radiation for this or that, and it was terrible. And there certainly are other disease states, like head and neck cancers, for example, where people are getting radiation to their head or neck that definitely can have a lot more toxicity. But for prostate cancer, we're dealing with a pretty small organ way down in the pelvis. And in general, the side effect profile is pretty favorable, and we'll go into that. So there's a couple different types of radiation. We'll talk a little bit more about this. So there's what's called 3D conformal radiation, intensely modulated radiation, or IMRT, stereotactic body radiotherapy, brachytherapy, which is more of a local implant type of radiation that's done from the inside out, and something called proton beam. As far as surgery, there's still some surgeons that may do the prostate removal open, the old-fashioned way with a bigger incision, but that's becoming more and more infrequent these days. Most of it's done with the robotic-assisted prostatectomy, as I just described. Again, the active surveillance, since the prostate cancer in many cases does grow slowly, we can just watch this versus doing any treatments that may have potential side effects. And some of those side effects do include some urinary issues such as urinary incontinence, erectile dysfunction, and bowel side effects, mainly from radiation, not so much from surgery, but that can cause some loose stool, diarrhea, some bleeding with stool, things of that nature, and we'll get into that a little bit more. So radiation treatment overview. So the radiation is, I describe it to patients, it's like a big fancy x-ray machine. So if you can lay on a table to get an x-ray, you can lay on a table to get external beam radiation. So prostate radiation therapy uses directed radioactive exposure, such as high energy x-rays, to kill the cancer cells and surrounding tissue. Separated by a small space, radiation often unintentionally can cause some damage to the rectum. With the modern radiation machines, this is certainly much less than it used to be with some of the older technology, but there still is some radiation that gets to the rectum just because of the close proximity. So there can be some bowel dysfunction associated with diarrhea, blood in the stool, or some stool leakage, as well as some urinary dysfunction, such as urinary frequency, having to go more often, some burning with urination, blood in the urine, or some urinary incontinence, although certainly urinary incontinence is much less common with radiation than with surgery. So the external beam radiation therapy, there's the 3D conformal. The main one we do in our practice is called intensity modulated radiation therapy, along with image guided radiation therapy, where basically the intensity modulated kind of adjusts the radiation beam to the tissue dimensions. So you're really focusing the radiation just on the tissue that needs to be treated to try to minimize any side effects to adjacent structures. And the image guidance basically makes sure that the patient is lined up properly every single day. So even though the prostate obviously is always in the same place, there can be slight variations depending on bowel gas or things of that nature, and patients may not be lying exactly in the same spot on the table every day. So doing image guided radiation therapy makes sure everything is lined up appropriately, again, to minimize side effects. Stereotactic radiation, another form of external therapy, and proton therapy is just a different type of radiation energy, but also is fairly widely used for prostate cancer. Internal therapy, so it's called brachytherapy. This is also known as a seed implant, where you can put in little radioactive seeds or radioactive pellets into the prostate, which is typically a outpatient day surgery type procedure that takes an hour or two, depending on the size of the prostate. And these radioactive implants just decay over time, but while they're active, they do provide a dose of radiation to the prostate, kind of from the inside out. So this is a scan of a patient. So this would be the cross-sectional view. So basically a patient kind of cut in half. So here's the oops, sorry, go back one. So here's the pelvic bones and the top of the leg bone. This is the top of the hip for orientation. So this is the front part of the pelvis, the pelvic bones. And then the prostate is here in the red. So that's what they're trying to target to get the most radiation. And then these areas around it, so the green and the blue are getting lower doses of radiation, but still a little bit of radiation because we want to make sure that we're treating the entire prostate. So you can see the rectum is right here. It's still getting a little bit of radiation on the top part of the rectum. And this is the same kind of picture, but more in what's called a sagittal view. So kind of cutting someone kind of front to back the long way. So we're seeing everything from the side. So here's the prostate, the urethra right up here going through the penis, and the bladder is up here. And again, there's a little bit of radiation dose to the bladder and a little bit of radiation dose that gets to the rectum. So the rectal toxicity, so retrospective analysis entitled Early Tolerance and Tumor Control Outcomes with High Dose Ultra Hypofractionated Radiation Therapy for Prostate Cancer. 551 patients received dose escalated radiation 269 of the 551 patients received this hydrogel SpaceOAR, which we're going to go into a little bit more. So the percentage of late toxicities with and without this hydrogel is significantly reduced. So we're going to go into a little bit more detail about the gel in a moment. So you can see here, though, the blue bars is patients who had the hydrogel, very minimal side effects as far as GI or rectal toxicity, and urinary symptoms basically cut in about half or more than half, and by sixfold with the bowel toxicity. So the conclusion here was the use of hydrogel SpaceOAR was significantly associated with reducing the GI toxicity and urinary toxicity as well for patients getting radiation. So what is this hydrogel? So the even with our modern techniques, you still get a little dose of radiation to the rectum. So the SpaceOAR Hydrogel basically is a 2-component liquid that is injected in through the perineum as a quick 5-minute little office procedure. And when you inject the 2 liquid components into an injection needle and they mix together, it basically forms a piece of jello-like material that lifts the prostate up off the rectum. So by making that space, those little green and blue lines that we saw earlier, and a little bit of this red in the top in terms of the dose of radiation to the rectum, all of this gets lifted up and away, so the rectum can more or less be spared any radiation dose. And this basically will dissolve by itself after several months. So the normal course of radiation treatment is somewhere in the 8 to 9 week range, sometimes a little shorter. But either way, the SpaceOAR hydrogel will dissolve by itself in the body after a few months, and it's the prostate goes back to its normal location. So what does the OR stand for? The OR stands for organ at risk. So in this case, the rectum is the organ at risk. So the rectal toxicity can cause a little bit of bleeding, frequency, urgency, pain, very rarely what's called a fistula, which is an abnormal connection between these 2 structures. So as I just showed you again, if you have that little halo of radiation dose that gets to the top of the rectum, by putting that hydrogel SpaceOAR in there, it just lifts everything up and away. So when we actually do these procedures, you can actually see under ultrasound guidance the prostate being lifted up off the rectum, which definitely can help preserve quality of life as you're minimizing any radiation injury that can cause urinary, sexual symptoms, and bowel side effects. So again, it temporarily positions the rectum away from the prostate. It can reduce rectal wall exposure. It's a brief, typically about 5-minute outpatient procedure. And again, after about 6 months, it's naturally absorbed and removed through the urine. So it's synthetic, biocompatible, non-toxic. It absorbs about 6 months. It's basically made of polyethylene glycol, which is similar to, if anyone's ever done a colonoscopy, this is similar to that's what's in the bowel prep or Miralax. So if you've ever taken that for constipation, that's what this polyethylene glycol, it basically, pulls water into the gut and makes people get cleaned out for a colonoscopy. So it's a similar material that's certainly biodegradable. Brief outpatient procedure, local, regional, or general anesthesia. We typically do it either local or with a little bit of twilight anesthesia in our practice, but takes about 5 minutes. And it's been well clinically studied, designed to provide space between the rectum and the prostate. Control patients were 8 times more likely to have a decline in bowel, urinary, and sexual quality of life when compared to the patients who got the hydrogel at about 3 years. So in terms of clinical results, when you have more space, you have fewer rectal complications, fewer urinary complications, fewer sexual complications, and a better quality of life. Again, 8 times more likely to have a decline in bowel, urinary, and sexual quality of life if you don't use the SpaceOAR. If you use the SpaceOAR, all those parameters improve. So it's been studied in about 75 or more peer-reviewed publications, probably more at this point since the slides, I think, from last year. It's used in many of the leading cancer centers in the United States. Most of the large prostate cancer centers, certainly in the Chicago area, do this. We've been using this in our practice on pretty much all of our radiation patients, unless there's some contraindication, for at least the last couple of years. It is paid for by Medicare and most private insurance companies, and there's been more than 50,000 patients treated with this technology worldwide. Certainly any additional questions, spaceoar.com can have additional resources. and they do have patient helplines, additional educational materials available. And with that, that's the